And don't forget to ask questions in the specific written device.
Exactly.
Yeah. Good afternoon, and Ayubowan, which means may you live long in Sinhalese. I am Sanjeeva Malinda from National Hospital for Respiratory Diseases, Sri Lanka. And today we are going to, I do not have any conflicts of interests. So today we are going to discuss about evaluating a tuberculosis patient with persistent fever and evaluating fever and cytopenia in a tuberculosis patient and management challenges in treating tuberculosis with persistent fever and sharing knowledge about diagnosis and management about a fatal complication of tuberculosis. Yeah, we had a 22-year-old girl who had type 1 diabetes for 8 years duration with poor glycemic control, presented with cough, dyspnea, evening pyrexia, loss of appetite, loss of weight for 3 to 4 weeks. She did not have any family history of autoimmune conditions or hematological malignancies. Upon examination, she was thin-built, was looking ill, dyspneic, and febrile. She did not have any features of connective tissue diseases. She did not have lymphadenopathy. She was tachypneic and tachycardic. Blood pressure was stable, and saturation was 93 on oxygen 2 liters. And she had bilateral cause crepitations on chest auscultation. At the emergency room, we did the arterial blood gas, which showed respiratory alkalosis with severe hypoxia with a PaO2 of 52. Her ECG shows sinus tachycardia, and the capillary blood sugar was high. Her chest X-ray showed bilateral diffuse irregular opacities, and the high-resolution CT chest showed bilateral consolidations, cavitations with early bronchiectatic changes and mediastinal lymphadenopathy. So upon investigation, her full blood count showed neutrophil leukocytosis, her inflammatory markers were elevated, her renal functions and liver enzymes were normal at that time, COVID-19 PCR was negative, sputum for acid-fast bacilli 3 plus 2 consecutive days, and sputum bacterial culture also isolated a Pseudomonas species, blood culture and urine culture were negative, and gene expert Mycobacterium tuberculosis detected without rifampicin resistant. Her retroviral strain was negative and she was started on anti-TB drugs. After 1 week of IV antibiotics and anti-tuberculosis treatment, she remained to have high fever spikes, clinically no improvement, remained to be tachypneic and tachycardic, but the oxygen demand was improving. She had persistently high inflammatory markers, and radiologically there was no improvement. After 2 weeks of IV antibiotics and anti-tuberculosis treatment, her high fever spikes continued and repeat cultures were negative. Remained to be tachycardic and tachypneic, again, the oxygen demands are slightly improving. But she had persistently high inflammatory markers, radiologically also, again, no improvement. So the question time, we can start voting now. What are the reasons for prolonged fever in a pulmonary TB patient? Okay, we can go to the next slide. Yeah. The answer is all of the above, like most of you have picked up, because direct effect of TB due to severe infection can cause prolonged fever, and concealed abscesses can give rise to prolonged fever, and drug resistance can give rise to prolonged fever, and drug reactions, especially rifampicin-induced fever or INH-induced lupus, can give rise to prolonged fever. So the answer is all of the above. So we further investigated repeated cultures, blood, sputum, urine were sterile, and 2D echo did not show any evidence of infective endocarditis. The inflammatory markers were gradually decreasing, but a full blood count, we detected the cell counts drop. Malaria screening was negative. Ultrasound scan abdomen didn't show any concealed infection. Blood picture shows evidence of bacterial infection and slight mild iron deficiency anemia. Her thyroid profile was normal. ANA and rheumatoid factor were negative. Sputum for fungal studies, serum IgE, aspergillus-specific IgG were negative. So this is a trend of a full blood count, as you can see. So you can see there's a clear drop of white cell count and HP. And although the platelet count looks normal, you can see there's a steep drop from the initial count. And there's elevation of liver enzymes as well. So again, the question time, you can start voting. What are the causes for developing cytopenia in this patient with pulmonary TB? Okay, most of you have got it correct. The next slide, please. Previous slide, please. Yeah, the answer is all of the above. Severe sepsis can give rise to, yeah, previous slide, please. Previous slide, yeah. Serious sepsis can give rise, serious sepsis with co-infection can give rise to cytopenias, and disseminated TB with bone marrow infiltration can cause cytopenias, and anti-TB drug-induced immune-mediated destruction of cells can give rise to cytopenias. Anti-TB drug-induced bone marrow suppression also can give rise to cytopenias. And apart from that, immune dysregulation leading to destruction of cells also can lead to cytopenia. So the answer is all of the above. Next slide, please. Yeah. So we further investigated. She had very high serum ferritin levels, 4,860, and her triglyceride levels were elevated. Repeated ultrasound scan abdomen showed splenomegaly, and her antihistamine antibody was negative. So we planned for a urgent bone marrow aspiration refined biopsy, which showed increased number of macrophages, and macrophages with the ingested cellular hemophagocytic activity. And her bone marrow TR was negative. And the diagnosis of hemophagocytic lymphohistiocytosis was made with confidence. So again, the question type. Which one of the following is not a diagnostic criteria for HLH? Okay, the next slide, please. Yeah, there are mixed responses. The lymphocytosis is not a diagnostic criteria of HLH. Okay, so TB, tuberculosis, and HLH, it's a management challenge because anti-TB drugs and HLH both can cause liver damage, and anti-TB drugs can cause cytopenia, skin rashes, and drug-induced lupus, which can mask HLH manifestations. And HLH-specific treatment-related challenges are also there, like dexamethasone, steroids, they suppress immunity, and it affects glycemic control as well, which can worsen TB infection. Etoposide, cyclosporine, immunoglobulins, and steroid pulses, all of them can cause immune suppression. And apart from that, etoposide can cause liver damage, which will become a problem when we next. Yeah. So the caution is incorrect diagnosis, incorrect clinical judgment to treat can be highly detrimental and even be fatal. As an example, if we give steroid pulsing a patient with severe sepsis masquerading as HLH could be fatal. And delaying treatment of an HLH patient thinking it as sepsis also could be fatal. So we called a multidisciplinary meeting team with participation of hematologist, microbiologist, endocrinologist, and general physician, and the respiratory physician. Then we decided to pulse with methylprednisolone 500 milligram per day for 3 days, followed by prednisolone 0.75 milligram per kg. We started desensitization for anti-TB drugs as soon as the liver enzymes became normal. And within days, she showed marked clinical and biochemistry improvement. So, main treatment strategies available for HLH. There are no randomized controlled trials. HLH 2004 and 1994 HLH protocols are the guidance. If HLH is not severe, can treat the triggering factor with added steroids and observe. But HLH-specific treatment includes etoposide and dexamethasone and intrathecal methotrexate if there is CNS involvement, central nervous system involvement. IV immunoglobulin plasma exchange have been used with varying success rates in various case studies. In refractory disease, cyclophosphamide, doxorubicin, methylprednisolone, etc. have been used, and hematopoietic stem cell transplants has also shown good results. So the key messages of today's presentation is TB is a well-known cause of fever in a TB patient should be promptly investigated, and cytopenia in a TB patient has many causes and some are fatal. HLH in TB patient carries high mortality and should be identified and treated early. TB-HLH combination has many diagnostic and management challenges. Treatment of the triggering condition is very important, and HLH-specific treatment protocols should be used where necessary. These are my list of main references. So thank you very much for your kind attention.
Well, thank you for this nice presentation. I remind you that you can ask questions and that we will have a final discussion at the end of all case presentations. So now we move to the third presentation, which is from India, Dr. Sivananda Raj. And